Kia ora everyone, welcome to tonight's Goodfellow Unit live webinar on drugs and sport and how it relates to our medical communities and primary care. And our expert speaker tonight is Professor David Gerrard. He is a specialist sports and exercise physician, predominantly based in Otago Medical School, and also is a previous Olympian himself and works closely with Drug-Free Sport New Zealand and the World Anti-Doping Agency. David has a real interest in education of athletes, those caring for athletes, coaches, and the medical community in terms of being able to help doping control become something that is well organised. Thank you, David, for joining us tonight, and I'll let you start your talk.
Yes, thank you very much, Helen, for those warm words of introduction, and thank you to the Goodfellow Unit for allowing me the opportunity to speak to something that I've spent probably the last 25 to 30 years of my clinical practicing life coming to terms with. As Helen said, I was fortunate enough to have a background in international sport, and in my misspent youth probably spent too much time in chlorinated water, which is the reason for the colour of my hair. Swam internationally, enjoyed a variety of sports, and then when the opportunity came to consider the pathway I would follow in medicine, although beginning my training in internal medicine and spending 3 years along that fellowship pathway, it was sport and exercise medicine that took my fancy eventually, and then subsequent to that, and now a retired professor from the University of Otago, as much as I still read the Otago Daily Times online each day, Helen, I am now a resident in Auckland, living just north of Auckland up at Hatfields Beach, for those of you that might know that part of Auckland. We're returning to my roots. So it's a pleasure to be here, and I want now to just outline the topic that we'll be dealing with tonight. And I'm really pleased, Helen, that you made mention of the fact that although the thrust of this talk will be for those responsible for prescribing drugs to athletes, I'm very, very mindful that in our audience we have nurse practitioners, we have pharmacists, we have physiotherapists and other healthcare professionals who represent what we know now today as the athlete entourage. And although you may not consider yourself to be sports medicine practitioners and working in a general practice primary care environment, it might surprise you the number of patients that come through your doors who have an obligation to consider the athletes, considering what medications they are using, and their medical providers to have the information and the responsibility for how they prescribe and how they confirm treatment in accordance with the international code for managing athletes in sport. So really, I hope that in the course of this evening, we'll touch base on a number of things. I should, just before I get to the aims of the talk, remind you that there are some very, very good resources that you can access. I would certainly recommend that you go to the website of the World Anti-Doping Agency. Just simply Google WADA, the acronym, which will bring up World Anti-Doping. Drug-Free Sport New Zealand, which has a plethora of good information that's really tailor-made for the New Zealand clinical environment. Most of you will be familiar with either MIMS New Ethicals or the New Zealand Formulary, and probably have a copy of it either on the desk, which is perhaps the old-fashioned way of dealing with these things, or you'll certainly have access to these online. And both the New Zealand Formulary and MIMS New Ethicals have a list of prohibited substances in sport. And so if you need access to check on the status of a drug, you have also an opportunity to get that information at your fingertips. The Medical Council of New Zealand I make reference to because they have a very, very significant part to play in the way that we practice medicine. And they've shown over the last few years a very keen interest in doctors who, for the wrong reasons, are prescribing banned drugs to athletes. And we'll make mention of that when I come to talk about our ethical responsibilities. Essentially, I'm going to hopefully put drugs in sport in a framework which will have an ethical and historic overview. Talk about our clinical obligations, be that from a medical, a nursing, a pharmaceutical, or a physiotherapeutic standpoint, what therapeutic use exemption is all about, and then hopefully to wrap all this up with a few case studies that I think will give us all an opportunity to bend our minds to cases in question. And hopefully, if I can convince or if I can leave one new fact with you tonight, then I think we'll have achieved what I set out to do. And we're not here to conquer the world in one webinar, but simply to raise a whole raft of issues. And these are probably the questions that I hope over the next hour we'll have provided you with either the explicit answers to, or the resources for you to be able to explore, research, and find out for yourself. So we'll spend some time talking about what drugs are banned, the reasons for their being added to the prohibited list. I'm not going to give you an explicit list of the many pages of banned substance, but rather the categories that should ring alarm bells for you if you're confronted by an athlete who either asks for a particular substance or requires that for their obvious treatment. Many of you will not be aware whether or not your patient is an athlete and is liable to be tested. Now, that responsibility lies as much with your patient and the education that they should get when they reach the status of elite sport, when they become a member of the registered testing pool, which Drug Free Sport New Zealand is then required to follow up and test in competition and out of competition. So there's a bit of shared responsibility there. What your medical obligations are, this will become a bit clearer when we delve into the actual and tease out the definition of what we understand by therapeutic use exemption. And then finally, I would hope you'll all go away from this webinar much more familiar with the sources of information and the resources that are literally and figuratively at your fingertips. So let's say something about drugs in sport, and those of you that are interested will well be aware that as far back as ancient gladiatorial times, it was widely reported that substances that were contained in hallucinogenic mushrooms and various other potent forms of stimulants were being used by gladiators to enhance their performance. I suspect that if I was a gladiator of that era, I'd be looking for some hallucinogenic substance, a stimulant, and perhaps a little bit of Lomotil to help me along the way. So history has provided us with a rich source of the genesis of the early use of performance-enhancing substances. We fast forward many centuries to the first time it was reported at an Olympic Games, and these were the Olympics of 1904 in St. Louis, where the gold medal was won by a gentleman who along the way was supported not only by his entourage, whom you see here now helping him along, which is forbidden, of course. You can't gain physical assistance. But he was also physically and pharmacologically enhanced by the use of a mixture of strychnine and brandy. And I'm not quite sure what the pharmacological or physiological basis for that combination is, but I mean, I'm partial to a convivial glass of brandy in an after dinner setting. I'm not quite sure that the strychnine will do much for me, or in fact for Thomas Hicks. He struggled, he made it to the finish, but they say that he wouldn't have needed much more strychnine or much more brandy to have actually succumbed as a result of running this marathon. And I'm sure by today's standards he wouldn't have been attired with the latest pair of Nike running shoes and all the other paraphernalia, nor the training. He was the son of a coal miner and worked in a similar environment. He looked there he is, bottom right, a fairly strapping sort of a guy, but I don't think by today's standards he would be considered to be your your stereotypical marathoner.
No.
So that was an interesting little sideline. We again leap ahead several years to the Olympic Games of Seoul in 1988 rather, and I was there as a New Zealand Olympic team doctor, and I saw Ben Johnson win the 100 metres. He narrowly headed off Carl Lewis and Linford Christie. Carl Lewis, the American, of course, who himself was under a bit of a doping cloud, and Linford Christie subsequently was shown to have used performance-enhancing drugs. But on the day, it was Ben Johnson who got picked up, the laboratory in Seoul, picking up traces of a very potent anabolic steroid by the name of stanozolol. I think back to those days, he was quietly distanced. The Canadian team was so excited at winning a gold medal. It was their first Olympic gold medal ever on the track in the sprint. I was sitting with the Canadian team doctor, Professor Andrew Pipe. We shared in the Commonwealth victory, and then within 48 hours it was publicly announced that Ben Johnson had returned a positive test, and slowly but surely he became a Jamaican Canadian. Then he became an expatriate Jamaican, and slowly but surely the Canadians disowned him. And his entourage. Dr. Jamie Astafan was his doctor and Charlie Francis his coach, both in for their clip of the ticket. And I think the sadness of these scenarios is that behind every cheating athlete there's a malpracticing physician and a coach that, is, as I say, in for his take. And that was the case with Ben Johnson. Very sad, because Ben was known, and I'm not being unfair and saying he wasn't the sharpest knife in the drawer, but he was a very powerful athlete, very talented athlete, and he was given clearly a significant advantage by using an anabolic steroid. The first Olympic gold medal to be lost at an Olympic Games through a positive test. About the time I was swimming, and it was during the period of the 60s through to the early 80s, and swimming internationally, the East German athletes they reigned supreme in track and field and swimming, particularly the women. And at the time we thought it was the legacy of the sports medical practice, the exercise physiology, the sports nutrition, the sports psychology, the extremely competent rehabilitation that was available to these athletes. And we thought that's why the East Germans were the best athletes in the world. Well, those contributions were undoubtedly important in the development of the GDR in sport. But what we didn't know at the time, and it wasn't until 1989 and the dissolution of the, or was it 1998 when the Berlin Wall came down? It was 98. The reports, the Stasi reports that outlined the use of anabolic androgenic steroids, the experimentation that took place mainly with the female athletes of the era, were the icing on the cake for those very gifted athletes who were then performance enhanced by the use of what was referred to in this wonderful book by Stephen Ungerleiter as chemical alchemy, turning their performance literally into gold on the track, and it did a huge amount for the socialist government of the time. So this was political intrusion in sport through the use of a state-sanctioned anabolic androgenic steroid enhancement. One of the casualties, and a well-described casualty of this era, was a young female by the name of Heidi Krieger, seen here in the photograph being held by herself, because this is Heidi some 20 years later. Heidi had been the product of the East German doping machine, and she had been receiving supratherapeutic doses of androgenic anabolic substances for a period of about 10 years, during which time she developed what we now know as a condition of gender dysphoria. She had lost most of her femininity in terms of her phenotype. Of course, she was genotypically still a female, but she was growing more and more male in her phenotype. Menstrual dysfunction, hirsutism, male pattern baldness, the clitoral hypertrophy and breast enlargement. She was diminished breast size. If you're a male taking anabolic steroids, you develop enlarged breasts, of course. But what she found over this period of time, she was feeling less and less comfortable as a woman and more comfortable as a man. Now, ultimately, she had reassignment surgery. She transgendered completely and is living happily and is married, oddly enough, to another East German athlete of the period, a female who'd been a javelin thrower, pentathlete actually. And they're a couple in Berlin, living happily, living a normal life and enjoying what has occurred, but through a very tumultuous time. And I just point this out to you that there was a number of very significant casualties to that era, and those personal consequences can't be understated. And that's just a little historic aside. Tragedies that have occurred as a consequence of the use of drugs were reflected firstly in the Olympics of Rome in 1960, where in the cycling team time trial, a Danish cyclist by the name of Knud Jensen was struggling. This was in Rome in heat, the ambient temperatures of mid-30s. So all the athletes were stressed. But what accounted for Knud Jensen's extreme distress was the use of amphetamines, which at the time were relatively commonly used in cycling, and nobody seemed to worry too much about it. This is in the pre-drug testing era. It wasn't until Mexico City in 1968 that drugs were tested for. So this was something which was very much in an experimental phase, and Knud Jensen suffered the ultimate in terms of losing consciousness, dying on the way to hospital. He fell from his bike and sustained a significant fracture and concussion, and they thought that was his major problem. But by the time he arrived at hospital, he actually succumbed to the overwhelming effect of the hypothermia, the hyponatremia, and of course the amphetamines on board. And then, as if it was deja vu, another cycling death in 1960 in the Tour de France, in the well-known climb up Mount Ventoux, where a British cyclist, a professional, Tommy Simpson, succumbed in almost identical circumstances to Knud Jensen 7 years earlier. So there was very, very, very much alarm bells ringing in the international cycling community, and taken up by the International Olympic Committee, who immediately investigated the use of performance-enhancing drugs and implemented at the Mexico City Olympics in 1968 the first of their anti-doping strategies, which was, by today's standards, a very low level, but nonetheless the first vestiges of urinalysis for drug testing. Now we leap ahead, a couple of decades, and we come to the Armstrong era, whereas, unless you've been living on another planet, you will recall that this gentleman, an exceedingly talented athlete who had a medical history that most of you will know about, testicular cancer, recovered from cancer, and then returned to cycling and won an unprecedented 7 consecutive Tours de France. And at the time, and continued to say, I have never knowingly used performance-enhancing substances. He'd succeeded in never returning a positive test. We now know in hindsight that this was due to some very, very significant medical oversight and advancements in sports science that had Lance Armstrong and his team of the time well ahead of the play. And he wouldn't get through today with the sophisticated laboratory analyses, gas chromatography, gas chromatography and high mass spectrometry would detect anything that he was taking. But in those days, and before the tests for EPO and the cocktail of substances that he was taking, he got through, and the rest, as they say, is history. Which is a bit of a segue into the next facet of my talk, and that is where the ethical boundaries lie. This is Dr. Michele Ferrari, who was the medical advisor to Lance Armstrong, and a number of other athletes, who was an outstanding physician. He was an outstanding sports physiologist, exercise physiologist beyond compare, but turned his countless energies and skill to the dark side, and was instrumental in manipulating the cycling cheats of the era, and manipulating them in such a way that they were able to beat the tests, which raises, the ethical issues of our duty of care, where the line is drawn between misusing a drug, in other words, using it for other than its intended clinical purposes, which is where I draw the line, and I say that's the definition of drug misuse. First, do no harm, non-maleficence, primum non nocere, the ethical standards by which the Medical Council of New Zealand expects us to practice. The council came on board 4 or 5 years ago with a cursory statement, which they've since upgraded and related to the WADA code, and they look and frown upon. They look very seriously upon any physician who is using drugs for other than their intended clinical purposes. And I would suspect too that the councils that administer nursing and physiotherapy and pharmacy will have a similar code of ethics and similar statements on their website, perhaps not specifically relating to sport medicines and sport, but nonetheless having the same ethical overtone. So I think we need to bear that in mind as we move on through our clinical practice, and specifically as it relates to the use of medicines and young aspiring athletes. Now, the most significant influence over the last 2 decades has been the development of the World Anti-Doping Agency, based in Montreal, the international body that is funded 50-50 by governments and the Olympic movement. So you have an investment by countries who want their athletes to be playing by the book, and you have international sports bodies through their allegiance to the International Olympic Committee, ensuring that their sport is clean. And we all know that over the last couple of decades, there have been some sporting codes where drug misuse has been rampant, as there have been countries where there have been practices that we've frowned upon, and the recent problems related to Russia. I referred earlier to East Germany, and there have been other communities of sport within the global sphere that have raised eyebrows. The World Anti-Doping Agency is responsible for the administration of what's known as the Anti-Doping Code. They have a list of experts who look each year at what is known as the banned list, and we'll talk more about that in a moment. They accredit specific laboratories to do nothing other than analyse blood and urine tests for sports anti-doping. So you've got laboratories that are very highly technically capable of measuring the concentration of substances in urine and in blood down to infinitesimal levels. They do work that is not the sort of work done by our normal medical laboratories. These are specific labs that are accredited, and they're the only laboratories that can actually administer the code and accept samples for testing. So you can't rock on down to the local medical laboratory and ask them to analyse a specimen of blood or urine and determine whether or not it meets criteria. These are laboratories that do nothing else but international and local testing for sport. WADA is also responsible for developing athlete and physician guidelines for compliance with the World Anti-Doping Code. And with respect to the list of banned substances themselves, to actually get on the list, a substance must meet 2 of the following 3 criteria. There must be clear evidence that this drug, if misused, could performance enhance an athlete. It must be shown that used inappropriately, and I'll give you examples in a moment, it would be harmful to a normal, healthy athlete. Or that it thirdly contravenes the spirit of sport. Now, any 2 of those 3 means that a substance could be placed on the banned list. Now, if you use something like EPO, for example, take that as an example, we know that erythropoietin is a well-established performance enhancer in terms of its making oxygen more readily available through erythropoiesis. No question of its performance enhancement potential. So it ticks that box. Is it harmful to health? Well, yes. When athletes in the 70s and 80s were actually experimenting with EPO, because people knew of its potential, they were working on the assumption that if 1 milligram of EPO was good, then 5 milligrams or 10 milligrams would be 5 or 10 times as good, totally oblivious to the fact that the coagulopathy that came about as a consequence of increasing your hematocrit to 70 or 80% was very hazardous to health, and there were well-documented a spate of deaths in young Dutch and Belgian cyclists as a consequence. So that's a glaring example. Spirit of sport, that's where something like marijuana comes into the picture. The debate about performance enhancement is very questionable. There are some people who say that, yes, marijuana will enhance your performance. I think it might disinhibit you and make you feel that you're invincible, but whether in fact your performance is actually made better or worse is questionable. Harm to health, well, we can debate that, and I think there is very firm evidence that marijuana is harmful to health. So even if the performance enhancement is questionable, the harm to health, we tick that. And spirit of sport, well, it's not a good look, is it? For Valerie Adams be having a bit of a puff on the sideline before she comes up for her next. That spirit of sport issue is a bit, motherhood and apple pie, but nonetheless, it's a very, very important criterion. And 2 of 3 mean that a substance is placed on the list. Now, we're not here tonight to litigate the list, and I'm not here to argue in favour of or against the substance that we'll be discussing shortly as being prohibited. The list is the list, and what we must do is to implement the list. And in terms of therapeutic use exemption, if a substance is on the banned list and we choose to use it for legitimate medical reasons, then we must justify it, not argue that it shouldn't be on the list. So what are the major classifications? Now, if you really want to put yourself to sleep, go to the WADA website and scroll through the banned list. It's not rocket science to think and understand that anabolic androgenic substances, stimulants, peptide hormones such as EPO and other growth factors would clearly justifiably be banned. You might question beta-2 agonists, thinking of their ubiquitous use in asthma medication, for example, glucocorticoids. How could hydrocortisone or prednisone have a performance-enhancing effect? It might make you a little euphoric if you're taking systemic doses of prednisone for a long period of time. But, well, we're not here to debate that. I'm here simply to say to you, these are substances that are on the list. Beta blockade in shooters, anti-tremulous, for example, diuretics, masking agents, the use of IV infusions, justifying the use of an IV infusion which might dilute a sample of urine, which might eventually make it more difficult to detect the substance, or putting an IV line in through which you can administer some other fast-acting, short-acting EPO, an anabolic agent that might disappear quickly. So IV infusions is an interesting inclusion on the list of not so much a banned substance, but a banned procedure.
Yeah, so it's not just the drugs themselves that can cause the issues, it's the masking drugs and the diluting drug ability with IV infusions and all of that around it. So it's covering the whole aspect of it rather than just the single drug.
That's right. And we've got a couple of cases that we'll look at later on, and one of them relates to masking, and I think it'll be more self-evident. So the message to take away from this particular slide is the banned substances are categorized. It's a very logical categorization, and we're not here to go into detail, but bear in mind that every year substances are mostly taken off. It might be found that there's something that's listed within one of these categories that's hardly ever applied for. It hardly ever turns up. So it's put on a subsidiary list, and it's not considered to be a primary concern. But more about that.
David, we've just got one question come through saying, are there significant differences in the banned drug lists between WADA and the international governing bodies such as UCI?
A very timely question, and the answer is no. All the international federations, the UCI, the International Cycling Union, FISA, which is rowing, FIFA, soccer, FIBA, basketball, FINA, swimming, they all must comply as signatories to the WADA code. They must comply with this list. You can't say that anabolic steroids are banned in weightlifting, but they're permitted in swimming. So the answer to that question, very timely, very good, is that all signatories to the WADA code, be they governments or international sporting federations, must comply with the list. Now, where does Drug Free Sport New Zealand fit into this? Well, think of Drug Free Sport New Zealand as being the WADA outpost in our part of the world. Drug Free Sport New Zealand is, of course, code compliant. It undertakes a national testing program based on the fact that certain athletes, once they reach an international status in New Zealand sport, will be placed on a list, and they then are liable to be subjected to out-of-competition testing or in-competition testing. And their urine samples will be sent to the nearest WADA-accredited laboratory, which happens to be in Sydney, in the suburb of Pymble in New South Wales. So blood and urine samples will be sent to Australia for analysis. So there'll be a registered testing pool of New Zealand athletes who will represent our predominant sports. And during an Olympic or a Commonwealth Games year, there might be an extended group of athletes who are added to the registered testing pool in preparation for their international competition. So there's a pool of athletes under whom, or over whom Drug Free Sport New Zealand have some supervisory capacity, and they are exposed to the national testing program. Unfortunately, this is a very expensive process, $1,000 a hit for a test. So you can't go down to the junior schoolboy rugby levels or down to club rugby or rugby league, where we know that there is a tendency, and let's not have our heads in the sand over this. We know that there's probably at that level, sub-elite, there may be people who have a dalliance with drugs in terms of performance enhancement potential to get to the next level, to get a contract, to gain admission into the elite segment. Drug Free Sport New Zealand have a medical advisory committee, and I'm honoured to be chair of that group. We also administer the Therapeutic Use Exemption process. Drug Free Sport have an excellent athlete education program, and they have a number of helpful documents there that are available to doctors and allied health professionals who want to know more about this, and have brochures available in their offices, or have opportunities to refer their athlete patients to the work of Drug Free Sport. So I wave the Drug Free Sport banner very, very avidly and say they are a wonderful resource, and also can be contacted through their 0800 Drug Free Sport hotline for any information, either you or your patients. So let's get to the nitty-gritty of what therapeutic use exemption is all about, and I think that's the fundamental message that I want to leave with you, with all of you with tonight. As I said at the beginning, I understand that in the audience we'll have primary care doctors, we'll have nurse practitioners, we'll have pharmacists and some physiotherapists, all of whom play a very, very important role. Most of what I'm going to be saying in the therapeutic use exemption area is directed to the prescribers, and that'll be primarily the doctors. I know there are nurse prescribers out there, but it's unlikely that they're going to be the primary initiators of an application for therapeutic use exemption. In fact, it requires a medical practitioner to sign the application, and we'll say a little bit more as we go through. So that's fundamental to this, the right of the athlete to have appropriate treatment, irrespective of the WADA code and the prohibited list. It, by definition, therapeutic use exemption, or TUE, infers the use of a banned substance where the patient's health is the primary concern, and that's always our primary concern. However, it does require compliance on the part of the doctors and the healthcare professionals who are responsible for this process. And I make the first of many references to diagnostic criteria. And we've got a couple of case studies that highlight this. But good note-taking, good fundamental establishment of a clinical diagnosis is paramount. And it's paramount for a number of reasons. Predominantly, if an athlete does stumble somewhere along the line and returns an adverse analytical finding, which is code for a positive test, if the doctor's notes are there to substantiate the use of a banned substance and it's all clearly defined, then there's a good chance that that athlete's livelihood and reputation can be preserved. So the doctors have an essential and critical role in this whole process and a responsibility. So let's just say that you as a primary care doctor have made an application for therapeutic use exemption. It comes to me as the chair of the Drug-Free Sport TUE committee, and I convene a committee of 3 other specialists, and we go through each application asking ourselves these questions. If we denied the athlete this treatment you've asked for, would the athlete's health be seriously impaired or risk a danger? Now, let's take something like type 1 diabetes, insulin dependency. Well, of course, if they didn't have their insulin, which is on the banned list, they would come to serious harm. Yeah. So that's a no-brainer. We don't have to go any further. We then ask the next question. If in giving this athlete the medication which is banned, let's say it's one of the banned beta-2 agonists, if treating this asthmatic with this beta-2 agonist, I am returning them to a normal state, that does not represent performance enhancement. It's supra therapeutic use of a substance. So I hope that makes sense, that there is absolutely no performance enhancement in my administering or you administering this drug to the athlete. And that should be self-evident in the way that you've administered and also applied for the use of that substance. Thirdly, are you missing out on using a permitted option? You know, is there something else that you could have used? You've gone for the systemic use of a glucocorticoid like prednisone to treat hay fever because this athlete has a serious allergic rhinitis or is atopic. When you are permitted to use inhaled glucocorticoids, or you can use topical glucocorticoids. But the moment you use systemic, you've got to apply for a TUE. So in other words, how well do you know the rules and the regulations? And if you're a doctor that treats a lot of elite athletes, you ought to be familiar with this. And so therefore that will be self-evident. If you haven't demonstrated that you've tried permitted alternatives and they haven't been successful, and that's why you've had to resort to a prohibited substance. And then fourthly, and this is a very, very rare occasion, I've probably met it twice or 3 times in the last 20 years, is the treatment that you're asking for the consequence of prior drug misuse. Now, the cases that I can think of, and they were all very much the same, males who had gone to their doctors complaining of gynecomastia and galactorrhea. They had breast enlargement and lactation, which they said to their doctor was probably something that they'd eaten or something in the water, or I'm making light of quite clearly the prolonged and chronic use of an androgenic anabolic substance in a male produces these substances. They were asking the GP to prescribe tamoxifen.
Oh my goodness.
All right, because they'd done their homework, they Google it, they know, and these athletes, all of them were bodybuilders and powerlifters. They were not what I'd consider to be mainstream sport, but nonetheless, their treatment was as a consequence of prior drug misuse. I hope I've made that example as a clear indication of what, and that's a rarity for us. We deal with the first three questions,
which is good. I'm glad that's a rarity. David, there's a question here. As a GP, we see and or do a lot of intra-articular joint injections using prednisolone. Does this warrant a TUE, regardless of the route, parenteral versus oral? I've been told that an intra-articular injection doesn't require a TUE.
No, you're quite right. You can apply glucocorticoids intra-articularly. You can apply them topically. You can apply them. You can use them through inhalation. But the moment you administer them systemically, now there is a little bit of a grey area out there. If an athlete comes in with hemorrhoids or some perianal excoriation and you're not sure of the extent of the problem, you can apply topical cream. The moment you use a Predsol suppository,
of course,
all right, you enter the nether regions. Systemic absorption is inherent in the route of administration, even though you're treating something which is fairly superficial. Nonetheless, you are treating them. That's the grey zone. The question that was asked has obviously been asked by somebody whom I imagine is a sports doctor and has access to and has dealt with athletes. Intra-articular injections are okay, but the moment, and this is the problem, if some of it leaks out into the periphery and is absorbed and becomes systemic, that's the grey area. Now, the laboratories will report a threshold urinary concentration of the glucocorticoid.
Okay, so they'll be able to assess.
And they would be able to assess. I would suggest that if you're not sure that it's gone into the joint, if you're worried, have no hesitation in lodging a therapeutic use exemption application. We will consider it. We'll see your clinical notes. We'll understand what you've done. And we're not here to put obstacles in the way of a practitioner who's mindful of the TUE process and has gone to that extent and is asking such a good question as that. I would back you all the way. So thank you for that, whoever you are, and put in a TUE if you're uncertain. But if you're sure that it's been a guided injection, it's gone into the knee joint, it's gone into the shoulder joint, it's contained within the capsule, you don't need a TUE. But if you're not sure that it's been absorbed systemically, it's kind of belt and braces stuff. I hope I've answered that.
I think that makes sense. There was one other question here, which is, are there differences that occur between brands, batches, variances based on the location of the production of a medication at any point in time?
Well, that's a question perhaps not for me in one sense, but then I will say that if you were talking to me about supplement use, I would say that you genuinely should be telling your athlete patients that supplements, probably most of them are the biggest frauds of the 21st century. We are seduced by the advertising. We overlook the fact that there's very little science behind many of the supplements. I've always been meaning to ask athletes who allow their names to be put to these supplements. I won't mention anyone's name, but there's a supplement being promoted on television at the moment, turmeric, a very famous husband and wife duo who swear by it. The science behind most of these substances, together with the batch testing, together with the the compliance to international standards of production, very, very shonky. And if you're talking about supplements, I'd say yes, there's a huge variance in batches. If you're talking about obtaining, basically something like prednisone from a pharmacist who knows where the drugs have come from. They haven't been manufactured in someone's, garage in Southeast Asia, but they've come from a reliable source. And pharmacists would have a much, much better understanding and probably a better answer to that question than I have. What I'm trying to do, and I'm not hedging my bets, I'm trying to say that in the course of treating athletes with drugs that you have access to, and they will have access through their dispensing pharmacists, I don't think we need to worry.
Okay. Yeah, I think that answers.
I've gotten a wee bit off the track with
Yeah,
that, but
well,
it did enable me to mention
Yeah.
the supplement thing, which is it's another talk for another night.
Yes, it's a whole other topic.
It is. So, okay, when it comes to you as the doctor applying for therapeutic exemption, how do you go about establishing this? Well, the WADA website has a list of very, very helpful diagnostic criteria and guidelines in common conditions in sport. And when you go to the WADA website, you'll find under medical information to assist TUE applicants, you'll see a list of conditions. There'll be asthma, there'll be ADHD, there'll be infections, there'll be hypogonadism, and the times that you can use testosterone and anabolic agents. There's a whole list of things that might be conditions that athletes may bring to the clinician for diagnosis and management in the sporting context. So in terms of the diagnostic criteria, and I'm not going to go through them all here now, that's the website that you ought to go to under medical information to assist applications for TUE. But what happens if suddenly someone, it's uncommon today, but goes into asthma crisis, in your surgery, and you have to treat them with anything you can lay your hands on, and you're not worried about the WADA code. You happen to know that this young swimmer is about to leave for the World Swimming Championships, and their asthma's been a bit bad for the last week, and they've come in and they've not responded to the normal medication, and all of a sudden they turn a little bit blue around the gills and they collapse, and you reach for whatever you need to. You treat them in an acute crisis, be it a status asthmaticus or an anaphylactic shock. You don't worry about the WADA code and the prohibited list. You treat the patient first, absolutely. And we can deal with the TUE later on if they're well enough to compete or they have an analysis done in or out of competition. If you're not sure and you don't happen to know, the athlete hasn't told you that they're about to burst onto the international scene and they could be going to the Commonwealth Games this year or the Olympics next year or the World Championships. They've said nothing to you. You have no reason to suspect. They've come to you for the management of their acne or their depression or their worries at home, and you have absolutely no idea of their status. That's important. It's not a safe option, because I think you've got to know your patients. There will be people who'll come across your door and you may never know until some weeks later that name rings a bell. I saw him. But the point I raise that now is that there is a little bit of wriggle room for us to then make a declaration retrospectively on behalf of that athlete. I use the example of swimming because a swimmer can stand up on the starting blocks as a non-registered testing pool athlete, dive in, swim 100 metres, set a Commonwealth Games qualifying time or Olympic qualifying time, and then suddenly be ranked top 5 in the world and be on the hit list for Drug-Free Sport New Zealand and the Air International Federation and be tested. Now, you were not to know that. In fact, the athlete they were hoping that they might achieve that status, but they weren't sure that it was going to happen so quickly. So there's wriggle room there to apply retroactively. Here again, and I mentioned earlier, the need for you to keep complete the records, the clinical records, and be very, very clear in your reasoning behind the treatment, as we hope doctors would do with all their patients, but we know how time pressures often don't allow that to happen to the same degree every time. And there is a retrospective clause that will enable us to go into bat for that athlete. And Drug Free Sport New Zealand is mindful of this. And if you've provided us with a complete clinical record after the event and some of these criteria apply, we will happily support your application and support your athlete patient.
One of the examples that has come up is giving steroids during a flare of inflammatory bowel disease.
Yes.
And I guess does that count? Or are you able to then apply for a retroactive TUE? Is this something that you've come across?
Yes, I have, and that's a good example. Chronic inflammatory bowel disease, not uncommon in young active patients, and I can think of 4 or 5 elite athletes over the last couple of Commonwealth and Olympic Games that have needed this treatment. And of course, the nature of their condition and the course that it runs is one of flare-ups and acute exacerbations, and often precipitated by the stress of training and competition and all sorts of factors we know of. So that's a good example where we would consider retroactive application. If the athlete has come and you need to treat them promptly, keep the good record. Make reference in your application to the fact that this athlete has been under the care of a gastroenterologist. They had their biopsy 10 years ago, so the diagnosis has been absolutely verified. This is not a first. If it was the first presentation of something that you thought might be chronic inflammatory bowel disease or an exacerbation of a colitis or something not yet determined, make the application nonetheless, but that's when we would say, well, we've got to engage a specialist to confirm your clinical suspicions. And again, we would look very, very kindly upon the responsibility that the physician is taking, even though all the ducks are not quite in a line.
It's about keeping those clinical records. Like you've really
exactly
pushed there.
Right.
That's the most important thing.
Could I just raise another point? And the questioner was right in using that very good example. It's just the use of the term steroids. And I know we do it, we've done it, and we will continue to do it. It's the way we talk in medicine. Oh, little Johnny was started on steroids last week for his asthma. The number of parents, friends, and others that have come to me and said, is this banned? Should little Johnny be taking steroids? Thinking that the steroids they're using were the same steroids that were used by Ben Johnson and Lance Armstrong and various other notables. I think when we're using this terminology, particularly to young athletes and their parents and the entourage, we make a very clear distinction between anabolic androgenic steroids and glucocorticoids, all of which are steroids or corticosteroids. And I know we euphemistically use the term steroids when we're meaning, I know that questioner was meaning a glucocorticoid, probably in prednisone. So just be mindful of the use of steroids, just a trap for young players, and sometimes patients pick up the wrong message, or they word around the trap says, oh, so-and-so's on steroids. Did you know that he's taking steroids? That's why he's so good. That's why he's so big.
That's right.
Well, actually, he's on corticosteroids, which are...
for a reason.
they're catabolic, not anabolic, and for a good medical reason. So a good question, and thank you, whoever that was. Now, Helen, I think we'll launch into the case
Yes, I think it's a good idea. Yep, I think we'll
going for time.
Good. We've got about 20 minutes.
20 minutes.
I think these are some good cases here that will bring up some questions. So
good.
I think let's go
through. We'll rattle on through these and just see how we go. The first one, and I won't read these. I presume you're all looking at them on screen, and essentially the take-home points are that this young athlete, let's assume she's on the registered testing pool. She's going to the national championships, and she's come to consult you for her seasonal allergy, and she's really stuffed up, and she's got an allergic rhinitis. And so, as you have done with many other patients, you administer a depot injection of Kinacort because you've done that before, and then suddenly you look up the wider list and you suddenly see that glucocorticoids, when administered systemically, require a TUE application. You think, my God, she goes off to the Nationals next week and wins the singles title and gets to the Commonwealth Games, and then she returns a positive test, for urinary presence of a glucocorticoid. Where is this going to leave you? So under those circumstances, you apply retrospectively or at the same time, and that often happens, sorry, I want you to know I've administered this. In fact, the half-life, and in a pharmacokinetic fashion, it's probably going to take 7 to 10 days for that to clear. And if there is that time frame and she's not actually competing until the weekend after next, she's probably going to be okay, because glucocorticoids are only tested for in competition.
Yes.
For reasons I won't go into, but that's the nature of the testing. They're not tested for at all times. Anabolic steroids all the time, EPO, stimulants, glucocorticoids only in competition. So there's a bit of a saving grace there. But it's a sober reminder for you to make sure that you know the status of glucocorticoids, and we've already mentioned that tonight. So this would be a case for a retroactive TUE. What information do you need to provide? Well, all the records that you would normally take. Could we have used alternative treatments? Well, in receiving your application, I'd say, did you use, she's all stuffed up. You're talking about a rhinitis. You're talking about an upper respiratory irritation. Did you try and inhale glucocorticoids? What about some antihistaminics? If this is a seasonal allergy, what else have you done? Or did you just go straight for the Kinacort? It's a salutary reminder that many ENT specialists don't condone the use of depot-based glucocorticoids anymore.
That's right.
But if you're worried, get a specialist opinion if you want to justify what you've been doing, and you may find that they'll come up with some alternative treatment. So I think the take-home messages for that case are: remember the status of glucocorticoids.
Yes.
Remember that there are permitted alternatives.
Yes, yeah.
And remember that you don't treat your athletes under the TUE process the way that you treat Joe. Nothing wrong with giving Joe Bloggs the Kinacort. It's worked for him, for the last 5 allergy seasons, so continue to do that. Let's be a little bit more mindful of the requirements for the athlete. The next one is a case of a soccer player who's had a knee graze, and he's just gone off to see somebody at an after-hours emergency clinic. He presents with a cellulitis. He's got a regional lymphadenopathy, and the doctor on call, on duty that night, quite appropriately says, "How long have you had?" "Well, it's been with me for a week, and it's getting, my glands and my groin are getting sore, and it seems to be spreading up my leg, this redness." And I think most of us would say, yes, IV antibiotics appropriate. Let's give them a good whack. Let's see if we can nail this. We'll do the other investigations and swab it and all the rest of it. And it is the clinic practice to administer probenecid, rightly or wrongly. So you do that, then suddenly you're alerted to the fact a colleague says, "Do you know probenicid's banned?" And you say, "Why the hell would it be banned? It's not performance enhancing." Well, it's not performance enhancing, but it's a very good masking agent. And we know that probenecid is given because it has a chelating effect, and it extends the effect of the antibiotic by diminishing its rate of elimination. And we know that, and that's why it's been standardly used. But it is, in fact, the laboratories have reported, clouding the issue of determining how you could pick up things like amphetamines and some of the anabolic androgenic substances. So if it's standard clinical practice, you've used it, you've documented that you want the patient to take probenecid for the next 3 or 4 days while you're transitioning them onto oral antibiotics as well. And you, again, keep records. This is not the athlete's fault. It's probably your fault for administering it and not knowing that it was banned and not admitting to applying for a TUE on the athlete's behalf. So there's a few swings and roundabouts, and occasionally I've had to ring some of these after-hours clinics and say, listen, guys, if you do that, just remember that if you're treating an athlete, keep the records and send them in with the application.
So it's not the end of the world if you've actually gone ahead and done it and remembered retrospectively. You can then, as you say, keep those records, apply, and let people know.
Yeah. The only problem with probenecid, it has a very individualized, it seems, its half-life is difficult. There have been cases, there was one case of an athlete not so long ago in Australia who returned a positive for probenecid 3 weeks after completing the course. Now, I can't account for that, and I don't know, but at the time it was thought it wasn't necessary to apply for a TUE. The laboratory reported the presence of probenecid, so their report was an adverse analytical finding for this. Please explain. And that caused a little bit of a furore. So the message here is, now you all know that probenecid is on the banned list.
Yeah. And that documentation, really
absolutely,
important.
once again. That's dead right. Our responsibility, but also the athlete should have said, listen, you know that I'm going to the World Champs next week.
They're probably so worried about their sore leg.
Yeah, that's right. Yeah. Okay, a rugby player who was diagnosed as a youngster with ADHD and has been well managed with methylphenidate and has used, as many of these athletes do, sport is a bit cathartic for many of them. It's many of them find that they can vent their spleen or their disorganized life or their inattentiveness is actually either masked or aided and abetted by playing sport, and particularly getting into a team activity. So this is not an unusual, not suggesting that all rugby players have got ADHD, but it comes up in a number of different things, gymnastics, swimming, you name it. Anyway, the points to take from this are that he was diagnosed as a child. He hasn't been reviewed for 5 years, and suddenly he's burst onto the national squad, and he's been selected for the junior All Blacks. He's now in the New Zealand under-18 squad and could be going off in the next couple of months for the World Cup. So he's now in the registered testing pool, and he's seeking a TUE because he knows he needs one, as does his doctor, for elite sport. Now, what are the diagnostic criteria for ADHD? Well, I'm not going to go through them now, but those of you who see a lot of patients with ADHD will be familiar with the DSM-5 criteria. They are a list of internationally agreed criteria by specialists in the field. They are part of that list of criteria that are on that wider website for ADHD. They require a specialist involvement. So you've got to have a pediatric psychologist or a pediatrician who works with kids with ADHD. You've got to have the instruments of psychometric evaluation and psychological testing. You've got to have those diagnostic tests available so that the diagnosis is well and truly established. Not a well-meaning primary care doctor who says, oh, little Johnny's a bit inattentive. Yes, he's probably got a variant of ADHD. Let's start him on Ritalin. And little Johnny does well, and mum and dad are pleased, the teachers are pleased. He starts playing sport, he becomes very good, his coach is pleased, and then suddenly becomes an elite athlete. We have to retrace the diagnostic process.
And in this situation where he hasn't been seen or assessed by a secondary care specialist for 5 years, what's that review period that you're looking at there?
Time, if that application came through and you'd said to me, well, this guy hasn't been seen for 5 years, even though he's seen by a pediatrician, has been managed, I'd say, let's get a review. Let's not break successful therapeutic intervention now, because he seems to be well on the methylphenidate. The Ritalin does him good. Leave it at that. We'll give you 3 or 4 months to get an appointment so he can be reassessed, and we'll review the application.
And he's clearly moved from the paediatrics through to the adult services.
That's right. That's the other.
Everything's changed.
Yeah, that's it. He's no longer a 15-year-old. He's now 19, 20. And so therefore we need to move into adult care. And particularly if he's going to go overseas and compete, the international Therapeutic Use Exemption committees will expect this. All right, so it's not only at a local level, they'll expect it. Okay, a triathlete, a 22-year-old triathlete who trains excessively hard, like most of the serious triathletes do, they train far too hard. He reports to his GP with a constellation of signs and symptoms including loss of libido, anorexia, fatigue, He seems to be falling ill of every virus that's going around. The typical picture. The GP runs a battery of tests, and the only thing that they come back with is an isolated low serum testosterone. And the GP says, well, actually a bit low in testosterone. I think we ought to apply for a TUE to have you receive supplemental testosterone. Well, it all sounds pretty good on paper, and so far it looks good. And the patient says, well, that's good, doc. You've given me, I've got a low serum testosterone. Even I can see that. The laboratory has put a big L below that. Beside that, I know that's below the norm. No other criteria have been assessed. And what this GP has missed out on, because this GP actually sent him for endocrine review, and even the endocrinologist that I spoke to was not aware of the fact that this patient was hypogonadal secondary to overtraining and fatigue. There were extrinsic factors that caused this. When you tested his hypothalamic pituitary end organ axis, there was nothing wrong with his production, and his pituitary status was normal. So he was not primarily hypogonadal. He was secondarily. And even though the endocrinologist said, are you telling me how to treat my patients? I said, no, I'm telling you how to treat athletes with secondary hypogonadism. Have you seen the linkage between overtraining and... So it was a learning curve for us all.
And we were talking about earlier how some of these athletes are very savvy and how they can come in and ask for testosterone measurements.
That's right.
On the basis that they may find that they're low and they may be given testosterone.
That's right.
In that kind of situation, I guess as a GP, you're still wanting to keep that relationship with your patient.
Totally correct. And I applaud the relationship you have with your patient, and that is very important. But I think it's a question of sitting down and telling them that, well, the bad news is that you're just going to have a rest for a month or two, and they won't want to hear that.
No, a triathlete doesn't like that.
No, well, you're going to have to cut back on your training. That there is a link between this, and I think you'll find that not only will your performance improve, you'll feel better, but this constellation of symptoms that you're complaining of, very, very important. It is a responsibility that rests with the primary care doctor, who's the attending doctor, and it's patient-doctor education here. And we're happy to come in. If you need me to lean heavily on the patient or be a little bit educative, not waving a big stick, but just saying, look, if you go overseas and you compete in an international event, and we submit a TUE on the basis of one low serum testosterone, with no other measure to substantiate the diagnosis for hypogonadism, you're going to be blown out of the water. And your TUE will not be upheld.
So again, it's getting advice, documenting well, and asking yourself or an endocrinologist or whoever that you need to get the extra information.
Totally. And going to the WADA website and those criteria. The final case is surprise, an asthmatic. A swimmer who's a bit brittle, her provocation tests and respiratory function tests confirmed a diagnosis of asthma, was seen initially by a respiratory physician, no question of the diagnosis, has been managed on a permitted beta-2 agonist, and in the beta-2 agonist list, there are 3 permitted beta-2 agonists, 1 long-acting and 2 short-acting, salbutamol, formoterol, and salmeterol. And also inhaled glucocorticoids are permitted. So you have an armory of mandated and normally very, very useful and satisfactory asthma medications to bundle them all up. Occasionally you might find that the athlete still has breakthrough symptoms. Maybe they're not well briefed in using their preventer. Maybe they're not using their glucocorticoid inhalation on a regular basis. Maybe they're not keeping their peak flow measurements done, bearing in mind that they're under huge stress with their training and their competition, and there's a whole overlay.
A young teenager.
And here she is, on the eve of the Olympic Games trials, and she has a flare-up, and she's getting really, really uptight, and there's a need for oral prednisone. So again, I hark back to the status of systemic glucocorticoids. your responsibility as the attending doctor, your record keeping, the early specialist endorsement. We know she's an asthmatic. She's been a bit brittle, increasingly more so over the last 6 months. And now in keeping with that scenario, we would accept that as a valid use of short-term use of prednisone, monitoring her, and ensuring that you're doing your bit in educating your patients in the management of their asthma. So there's a bit of a, you know.
We've just got a few questions that have come through that I think we should run through. One is a really important one here about whether a retroactive TUE has to be done by a medical practitioner, and are the athletes going to be disadvantaged if they are being treated by a nurse practitioner? And the nurse practitioner is the lead primary caregiver, which in New Zealand, you know, it does happen, and it's important aspect of how we manage this for these. It
is a bit unique.
Patients,
the code, unfortunately, says it must be signed by a registered medical practitioner.
Okay.
Now, if that came through from a nurse practitioner in our health system, and I'm appreciative of the status of nurse practitioners, what I'd suggest to that nurse practitioner is that you just get a colleague doctor to sign, not in any way to demean her clinical acumen or the need, but to preserve, particularly if the athlete's going to go overseas, and this has been signed by a nurse, it won't carry the status. This is not our decision. It's the international code requirement. So the answer to that is all TUE applications must be signed by a registered medical practitioner.
Okay.
But if in doubt,
yes,
I'm available, and I'm happy to talk that through any nurse practitioner who finds themselves in that position.
Fantastic. And there is, do you need a TUE if you prescribe intranasal fluticasone? I think.
Intranasal fluticasone. No. Well, just now, my clinical practice of last few years has been sparse. Using is that?
So I guess if you're using it for a sinusitis instead of
and the application is on the nasal mucosa,
yes,
is it?
That's right.
It's a topical.
Yep.
Topical
Spray.
Oh, okay. No, the answer is no. Yeah. By spray or by topical application. I haven't ever actually used intranasal fluticasone, but it all falls into place now. It's topical, and it's a combination of topical application plus spray inhalation.
So you're fine.
Not necessary.
Okay. No. With probenecid in your case study, would you apply and use, or use a different regime with no probenecid? Is getting a TUE a done deal in such circumstances?
Well, I'm also informed by people far better equipped to answer this than me that probenecid is actually being questioned. You know, its use in these situations. I think you'd need to ask that of an infectious disease doctor.
Whether it's a good
practice. It's good practice. If it's embedded in your practice and it's part of what everyone does, I'd continue to use that. My only concern is the length of time it can be measured in the urine. You know, its half-life. I have no idea what the why or how or for what reasons that we can get traces of it some weeks later.
Right. Yes.
Whether
that's
this is
right.
an individual aberration or I'm not sure, and I must investigate that because I've had it asked once before.
But it sounds like if it's something that you routinely use and you're documenting it well, as you say, and it's all sort of above board and you've applied, then you're really going to have a problem.
It's not a big task to sign off on a TUE application.
Like that.
The athlete can print it off, or you could download it, you could have some in your practice and then submit it, or submit it electronically to Drug Free Sport New Zealand.
Brilliant. And Viagra, there's been a couple of questions about Viagra, and will Viagra or similar be a banned substance to treat erectile dysfunction, causing psychological disturbances in a young male athlete?
No. Look, the quick and simple answer to that is, if it's not on the banned list, don't anguish it. Don't worry about it. Don't worry. There's 1,000 a month out there that we might think, no.
And is melatonin banned?
No,
No,
it's not
so
banned.
that's
no.
and the procedure for applying for a TUE. Now that's all very clear on Drug Free Sport New Zealand and on the WADA website.
Yes,
is that
it
right?
is.
So we can send out those links to people through our system here, and we'll be able to add that to our resources at the end of the webinar. So you'll be able to find that through our website as well.
Perfect. Now I've got 4 or 5 take-home messages. These will be very quick, and they may stimulate further questions. But let's just hope that you've all understood some of the principles that I've been burbling on about for the last hour. If you're a doctor that treats athletes, then you have an obligation to them as you would to any other occupational group within your practice. If you do airline pilot medicals, if you do insurance medicals, you know that you've got to follow in accordance with a specific set of rules that you wouldn't apply to your normal patients. Athlete patients are a similar occupational group. That's the way I like to read it. And maybe that will remind people that they have non-negotiable obligations to anti-doping. So that's take-home message 1. At all times, you as the provider to that athlete have the right to ensure that their health and welfare is your priority, and no one's going to challenge that. We're not going to argue. You are the person that saw the patient. You're telling me they had an anaphylactic reaction. I'm not going to dispute that. And you've documented it well, and you've submitted a TUE. That's fine. It's done and dusted as far as we're concerned. The fundamental premise of having this clause of therapeutic use exemption is a protection for athletes with genuine medical conditions. This opens up a whole hornet's nest because, what if you're in a country, what if you're in a sports federation where doctors are in for the take and they're writing out TUEs for the wrong reasons? Well, sadly, that is going to happen.
Does happen,
and we can't avoid those malpracticing physicians engaging in that, and it brings up the whole question of ethics. What I'm hoping you will understand is that you are giving your patient the right to receive their treatment and legitimizing their use of a banned substance and preventing them from having the anti-doping rule violation, the infraction, all the condemnation and the drama associated with that. Okay, take-home message number 4, and we've said this more than once tonight. Your records are really going to be the crux of the matter.
That seems the key here, I think.
It really is. And the number of times we've had doctors ring up and say, look, I scribbled a couple of things down. I can hardly remember seeing this patient. Well, I think if you're dealing with somebody who is an elite athlete, you're dealing with somebody who brings to you the responsibility of their occupational requirement. It is up to you to, to give clinical justification for what you've done. And I think that's a message that we don't need to repeat. So, Helen, I hope you and I hope the people that have tuned in have now understood a little bit more about what drugs are banned, or certainly the classifications. As to whether or not your patient is liable to be tested, well, they ought to know that. But if they're new to this and they're in a junior elite group or they're verging on international recognition, they may not. But the liability is there, and bear that in mind. If Valerie Adams walks in the door, you recognise her.
Absolutely.
But if little Jenny Smith, who's an up-and-coming swimmer, breaking through, you may not know that she's on the registered testing pool.
That's right.
Everyone's forgiven, as she would be for not flaunting her notoriety in sport, and that's all part of the process. Your medical obligations are no difference in terms of the ethics and obligations to your patient as they would be for any patient, with the proviso that you understand the anti-doping implications. I hope now everybody knows what therapeutic use exemption is, and also that there are some rich resources out there for their available information at their fingertips, and I hope that those questions have been answered along with a few others. And I with time permitting, I see there are a few other questions.
Oh, look, I think we could keep going with questions, though, and there's lots of lots of things out there about the different types of drugs, and I will refer back to the WADA website where you can go through all the lists of drugs there. So things that you've brought up here and things that you might think of afterwards, go and have a look and see if they are banned. It's very easy to navigate.
Yes.
And if in doubt, obviously there's always that contact through Drug Free Sport New Zealand, that you're there to give advice and education. And as you say, I think the ability to help if a practitioner isn't sure what they're meant to be doing in a situation with a patient. And I think in primary care, it is, we're doing so much in so different aspects. We really want those patients to be well, and then to have this extra on top of it, as very similar to that occupational problem, as a pilot or as someone else. It is really important to keep it in the back of our minds. And thank you, David. I think it's just been an incredible talk.
Well, thank you for having me. And I just want to leave the audience with the comment that don't be frightened to ask, and that's fundamental to your expansion of knowledge, and also in for the benefit of your patients, whether they're athletes or not. Asking is not a sign of weakness, it's a sign of strength. And I think we in Drug Free Sport New Zealand, the work that I do now, just generally consulting in this area, most grateful to people who take the time to ask the questions. And I don't know whether it's opportune to allow my email to go out, but perhaps if anybody does want to contact me, they can do so through Helen.
Yes, absolutely.
And I'd be more than willing to answer any individual questions. And so please don't hesitate to ask. And thank you all for being so attentive.
That's right. So if there's anything that we haven't got through, or any questions that we haven't got through, I think we got through most of them tonight, but if there's anything else, send it through to us and we'll pass it on to David and get the answers if we can. And looking forward to seeing you all next time. Thank you.